Good evening, everyone. Thank you for joining us this evening for an incredible webinar with Dr. Friedman. This is going to be a clinical presentation regarding the treatment of hypothyroidism and really an update. We had the pleasure of having Dr. Friedman when we were in our COVID lockdown a couple years ago, and he gave an incredible presentation on a variety of endocrinology topics. So Dr. Friedman is professor of medicine at UCLA School of Medicine, and he's also the Charles R. Drew University of Medicine and Science. He is the chairman of the Department of Medicine and the chief of the Division of Endocrinology, Molecular Medicine and Metabolism at Charles Drew University. He's board certified in internal medicine and endocrinology, diabetes and metabolism, and he always brought a lot of wealth and knowledge into the field. Definitely tons of publications that I've had the pleasure of reading. He's also an endowed professor in cardiometabolic diseases, and he's the director of the NIH-funded the Next Generation Substance Abuse Research Training at the university, at Charles Drew University, and also at UCLA, the NGSAR-TCU program. And he is the program director of the Accelerating Excellence in Translational Sciences, Cigarette Smoking Cessation, and Implementation, and a bunch of training grants really at Cal State University for training young scientists on smoking cessation and a variety of other endocrinology topics. So we had the pleasure of having Dr. Friedman again to really give us the latest and greatest on the treatment of hypothyroidism and all things thyroid. So Dr. Friedman, thank you for joining us this evening, and the floor is yours.
Thank you. Good evening, everybody. It's still afternoon in California, but I think in the East Coast it's evening. So we'll say good afternoon, good evening, everybody. As Sahar, I thank Sahar for a kind introduction and for inviting me to join you guys today. We are talking about updates on treating hypothyroidism. The outline of tonight's talk is going to be, first of all, thyroid medicine treatment options, the importance of measuring either T4 and T3 or free T4 and free T3, the difference between desiccated thyroid and synthetic thyroid hormones, some new articles showing patients prefer desiccated thyroid, talking about new thyroid hormone preparations, talking about T3 alone, talking about measuring reverse T3, talking about biotin affecting thyroid test, and talking about, finally, about a hypothyroidism diet. The thyroid, as people know, is at the center of the neck there. There's the thyroid cartilage. It has two lobes and the isthmus in between. It's right above the trachea. There are many treatment options for thyroid treatment. The most common ones are the levothyroxine, the LT4 alone treatments, levothyroxine, Synthroid, Levoxyl, Tyrosine, and Unithroid. There's products that are T4 gel capsules, Tyrosine, generic Tyrosine, and Thyquidity. There's T3 alone. T3 is Cytomel or liothyronine. There's T4, T3 combinations. There's desiccated thyroid. I'll be talking about this mostly today. Adthyza, Armour, Nature Thyroid, WP Thyroid, IRFA, which is from Canada. These are pig thyroids, derived from pig thyroid. They're often called desiccated thyroid, natural desiccated thyroid, NDT, or desiccated thyroid extract, DTE. There's a product that's over the counter called Thyroid Gold from New Zealand cows. That quite be helpful to people that don't want to eat pork products. There's desiccated thyroid levothyroxine combinations. And I think the important thing is the treatment needs to be individualized. We don't have one blood pressure medicine. We don't have one cholesterol medicine. We really try to individualize which patients will do the best on which type of treatment. The other important thing to realize is there's multiple studies showing that there's a poor quality of life among patients on levothyroxine replacement alone. It's somewhere estimated about 15%. I think it might even be higher than that. These are people that are on levothyroxine replacement for hypothyroidism. Their TSH is in the target range, and they're still feeling tired or run down and not feeling well. There's been several studies over the last sort of 20 years or so showing some benefit of T4, T3 treatment over T4 alone, although other studies haven't found the benefit. And I think it somewhat depends on the design of the study, if the T4, if the T3, the ratio of the T4 to T3, and if the T3 was given then a twice a day or multiple time a day dosing. It was a very interesting study published in PLS 1 in 2011, showing in Italy that a group of patients without thyroid hormone, without a thyroid, was given levothyroxine replacement. They had normal TSH levels, but 15% of them had a low serum free T3 level. This shows that certain patients have a different set point for TSH secretion. Some patients probably need a T4, T3 type of treatment to achieve normal free T4 and free T3 levels. And there's also been some emphasis in the thyroid literature about the importance of measuring free T4 and T4 and T3 in addition to TSH. This was a study that was published in Thyroid showing that clinical parameters are more likely to be associated with thyroid hormone levels than with TSH levels. A systematic review and a meta-analysis. The authors pointed out that there's stronger association with clinical parameters for free T4 than TSH. You can see that the association was higher for free T4 and free T3, above TSH really didn't have as much association. And currently, thyroidology is really focused on TSH, and that should be warranted reconsideration. That article pointed out of the importance of measuring free T4 and free T3 in patients. And I think it's really okay, we'll talk about this extensively during the talk tonight, to have a low TSH, especially people with pituitary problems, people on desiccated thyroid or T4, T3 combinations. And it also really supports measuring and replacing both T4 and T3, either by combination therapy or desiccated thyroid. In the Endocrine News, which is one of my favorite news art magazines, in July 2023, there was an article entitled Second Opinion, an interview with Rudolf Herrmann, who is an endocrinologist in Australia. And he talked about using a T3 inclusive perspective and measuring factors beside the TSH. He entitled this Rebirth of Endocrinology as a Unique Regulatory Discipline. The article wanted to point out about the disadvantage or staying away from a TSH-centric approach. And the point they make is that patients with hypothyroidism are getting more dissatisfied with their treatment options and even their physicians. There's been a couple of papers that really you have to look at the hypothalamic pituitary thyroid axis from a T3 inclusive perspective. And while TSH is important in diagnosis and treatment, it should not be the only factor, since many patients report residual symptoms in the presence of a normal TSH. There was an article in BMC Endocrine Disorders titled A Time for a Reassessment of the Treatment of Hypothyroidism. With this relatively direct title, the article served as a call for action to treat hypothyroidism, pointing to there's sort of an overshift and relying solely on TSH, a single parameter, and not looking at the whole thyroid picture. And Herrmann and his colleagues published an article in Frontiers in Endocrinology looking at the hypothalamic pituitary thyroid axis and felt that it was important to include a T3 inclusive perspective, especially since T3 is the active hormone. And this goes along with a study that's now about 15 years old from Paniker, looking in Journal of Clinical Endocrinology and Metabolism about the type 2 deiodinase that converts T4 to T3. They found that 16% of patients have this polymorphism, converting the T4 to T3. Patients with this polymorphism require a higher T4 dosing and had more psychological problems than those who did not have this deiodinase polymorphism. In this paper, they didn't really examine whether patients would benefit from a T4 to T3 combination. They didn't even measure the enzyme. They looked at the gene. However, I think this article was really eye-opening. A lot of people have trouble converting T4 to T3, and these are a good portion of the patients that are not doing well on T4 alone. And this challenged the idea that all patients with hypothyroidism should be treated with T4. And just like doctors use different blood pressure medicines, I think you certainly should consider T4, T3 combination in desiccated thyroid that contains the T4 to T3. And also, we'll talk about this a little later, T4 alone preparations can lead to high reverse T3, which can also be detrimental. And basically, the studies have shown that about 15 to 20% of the patients probably need a T4 to T3 combination to have an optimal effect on the thyroid. And these are the vocal minority, the people that are on their T4 and see their primary doctor once a year and they're doing fine. They're not going to complain. They're not going to need to see a thyroid specialist like myself or potentially some of the doctors in this audience that would benefit from giving them a little bit more than just a T4 treatment with a TSH measurement once a year. So what about desiccated thyroid? Desiccated thyroid has a higher T3 to T4 ratio than human thyroid. And then I find that patients on desiccated thyroid, especially Armour, and have a high free T3, a lowish free T4, and a low TSH. This is less so with NP thyroid and the new medicine I'm going to talk about today, Adthyza. They seem to have a little bit better ratio of T4 to T3, but at least traditionally patients on Armour were found to have a lower free T4. Our Armour is the sort of the standard one that people know about for desiccated thyroid. It's made by a company called AbbVie, distributed by Allergen USA. There was concern about the variability of preparations, lack of standardization, and I think these are basically unfounded. There's been for several reports showing that the desiccated thyroid is stable, standardized. There's not much difference in lots. So I think the product is a good product. AbbVie is not a small company. It has over 60 products. Other thyroid medicines were WP thyroid and Nature Thyroid. These are quite pure preparations. These were quite good. Nature Thyroid and WP Thyroid have been on back order for 4 years. They're made by a company called RLC Labs, and I don't see them returning, which is unfortunately are excellent products. So you basically have Armour Thyroid and NP Thyroid. NP Thyroid was recalled in 2020 for lot variability, but not in the last 3 years, and it's also an excellent product along with the Adthyza. I think one of the most important things that I like to emphasize that I think maybe is not appreciated by some of the doctors that use desiccated thyroid is desiccated thyroid has T3 in it. T3 has a half-life of about 4 hours. So the patients that get either desiccated thyroid or T3 as part of their T4, T3 combination should be given it twice a day. The T3 is really gone from the patient's system at the end of the day. They become hypothyroid in the evening and the next morning. And I think that's why a lot of patients don't do that great on a single dose, once a day dose, desiccated thyroid or T3. I usually give the second dose around 2 to 3 p.m. And I think the advantage of desiccated thyroid is also there's probably things in the thyroid makes that are not present in synthetic preparations. And I usually give the desiccated thyroid twice a day, especially in patients with poor quality of life on T4 alone. I like to separate by food by about 45 minutes. I think the 4-hour idea is sort of overblown. Usually about 45 minutes, most of the thyroid's absorbed, the food's sort of gone. And especially if you're consistent with that, I think the 45 minutes is a reasonable amount of time. I think a very landmark article publication was in the 2013 in Journal of Clinical Endocrinology and Metabolism by Wang and colleagues from the Walter Reed National Military Medical Center in Bethesda, Maryland. They did a randomized crossover study in which 70 patients completed the study and received either desiccated thyroid or levothyroxine replacement. They were on a stable dose of levothyroxine before and had a normal TSH before the study started. They didn't choose people that were not feeling well or anything like that. It was just random people on levothyroxine. They were 78 were randomized, 70 concluded the study with 35 receiving Armour thyroid at the beginning and 35 receiving levothyroxine at the beginning. There was then a crossed over to they got the other preparation. Both levothyroxine and Armour thyroid were given once a day. The dose of either the levothyroxine or the Armour was adjusted after 6 weeks, so the TSH was between 0.5 and 3. They continued on that dose for an additional 10 weeks. After 16 weeks, the patients were switched over to the other compound with the same adjustment at 6 weeks and continued for another 10 weeks. And the conclusions of the article, the results of the article was there was not a statistical improvement in symptoms for general health questionnaires or neuropsychological testing. However, there's a trend to improvement in these groups, in these tests, for the group that took the desiccated thyroid compared to the levothyroxine group. There was a 2.9-pound weight loss among the group that took the desiccated thyroid compared to the levothyroxine group that was statistically significant. The patients on Armour thyroid had a slightly lower HDL level, which is the good cholesterol, so that could be a little bit of a detriment, but it was just fairly mild. Both the total T4 and the free T4 were lower on the Armour thyroid group than the levothyroxine group. And that's why occasionally I give people on desiccated thyroid like Armour an extra dose of T4. And interesting that they didn't really comment on this, the reverse T3 was higher in the levothyroxine replacement group, and this may be detrimental. Most importantly, 49% of the patients preferred the Armour thyroid, 19% preferred levothyroxine, and 33% did not notice a difference. This was a blinded study, and they didn't know which thyroid preparation they were getting. So therefore, there was some subtle improvements that didn't show up on the surveys of health questionnaires, but they did feel like being on the Armour Thyroid better. They felt they were feeling better on it. The subgroup that preferred the Armour Thyroid lost even more weight. They lost 4 pounds on the Armour Thyroid compared to the levothyroxine. They had better well-being, and their thyroid symptoms were simply better with better cognitive function on the Armour Thyroid compared to the levothyroxine. And this suggests that, certainly a group of people do benefit from Armour Thyroid compared to levothyroxine. This was, again, an unselected population. They weren't people that were complaining. They're just healthy people that seem to like the Armour better. And these patients may be poor converters from T4 to T3, or may benefit from the other things that are in the Armour Thyroid. There really was no side effects in the Armour Thyroid groups. There was no increase in heart rate or pulse. The authors concluded that the improvement with Armour Thyroid may not be detected by the relatively insensitive methods used in the study, the surveys. They concluded that once-a-day desiccated thyroid in place of levothyroxine caused modest weight loss and possible improvements in symptoms of mental health without appreciable adverse effects. So I found this a very well-designed study. It was done in a very good journal with a reputable group, and that they did only give the Armour Thyroid once a day. Since Armour has a short half-life, I'd recommend twice a day. And I think they would have even had a better effect if they gave it twice a day compared to once a day. It clearly refuted the idea that Armour Thyroid is inferior to levothyroxine. So again, when this study came out, most people were against Armour Thyroid, most traditional endocrinologists. And I think the study started pointing the way that it's at least as good, if not better. And the study also pointed out the importance of trying to determine a subset of patients to put on desiccated thyroid. They did find that a significant subset of patients preferred the desiccated thyroid. The people that preferred the desiccated thyroid were more likely to have an autoimmune thyroid disease and had a slightly higher reverse T3, although neither of these were significant. And the study examined all patients with hypothyroidism. Most of them were doing well. And I think if they looked at people that were doing poorly, they would have even had a better effect. So this again points out that for many patients, the desiccated thyroid is going to be a good option. The group from the Walter Reed National Military Medical Center followed up with another study published in JCNM in 2021. It was a somewhat similar type of study, a very high quality study. But this time they had 3 groups: levothyroxine, desiccated thyroid extract, and levothyroxine plus liothyronine combination therapy. It was a prospective randomized crossover study like the other one. There was 3 arms: the desiccated thyroid extract, the LT4, LT3 combination, and LT4 alone. It was blinded, and they were assigned one of these 3 arms for 12 weeks and then crossed over. This shows the analysis. There were 75 used at the end of the study. 26 of them were assigned to levothyroxine, 27 to L2, T4, LT3, and 22 to desiccated thyroid. So for fairly small numbers here. Overall, 45% of the patients indicated they prefer desiccated thyroid as their first choice. 32% preferred LT4, LT3 as their first choice, and only 23% preferred LT4 alone. So about twice the number of people liked desiccated thyroid. There was no difference in the thyroid symptom questionnaire. The p-value was insignificant. For secondary endpoints of weight, general health, depression, memory, lipids, thyroid function, there was no significant difference. And they also looked at the polymorphism described by Paniker, and that had no effect as well. Dr. Wang presented at the 2021 Endocrine Society on one of these product talks. These are sponsored by the drug companies. In this case, it was sponsored by Acela. I thoroughly enjoyed his presentation. It was well attended. He advocated for once-a-day desiccated thyroid use. He advocated for monitoring TSH, which I don't really recommend. I think you have to look at the free T4 and free T3. And he also mentioned several other studies showing increased patient satisfaction on desiccated thyroid. There was subgroup analysis based on symptom questionnaires that they found that the symptomatic patients on levothyroxine improved, while those being treated with T4, T3 improved with being treated with T4, T3 combination or desiccated. So the patients that were symptomatic on T4, when they got switched over to T4, T3, or desiccated thyroid, they got better. And Wong added many patients would switch to from levothyroxine to desiccated thyroid extract, said they felt much better with more energy, less mental fogginess, a better outlook, less flare of lupus symptoms, and easier to lose weight. My comments on this study in the presentation at the Endocrine Society was the study was blinded. There was a small number of patients, but clearly the desiccated thyroid was the preferred product. They didn't look at patients specifically with hypothyroid symptoms. Those that have hypothyroid symptoms might do better. I think they would do better if they gave it twice a day. And I usually aim for, I don't really look at aim for a normal TSH. I think it's okay to have the suppressed TSH. And I like to see at least a normal to sort of highish normal free T4 and free T3. The Wang presentation pointed out some articles that I went in depth and pulled them all up. And I'll review them briefly here. There are 7 peer-reviewed articles, some in good journals and some in not so good journals, that show that desiccated thyroid extract was preferred over levothyroxine, and some articles showing it was preferred over T4, T3. This article here was published in Annals of Family Medicine, looking at stability in patients on desiccated thyroid versus synthetic. And they found that the TSH in both groups were in range 79% of the time. There's no difference between the T4 and the desiccated thyroid. So people were concerned the desiccated thyroid has more variability. Maybe your TSH would fluctuate more, but it showed that that wasn't the case. There was very similar instability, TSH stability between the desiccated thyroid and the synthetic levothyroxine. This article here published in Southern Medical Journal, probably a lower quality journal, in 2018. They were started on combination therapy of either T4, T3, or desiccated thyroid. If they had optimal trials of T4 for at least a year, they could have low normal free T3, which they define as 2.5 to 3. And they had whether they got natural desiccated thyroid or synthetic T4, T3 was based on physician and patient preference. And this graph shows SF20 outcomes. In general, and I'll show this more, talk about this more in the next slide, the patients on the desiccated thyroid did better than the T4, T3 combinations for most of the variables. And they all showed an improvement compared to the T4 alone. So in their subset population, the symptoms of hypothyroidism improved significantly with no increase in the hyperthyroidism. Most patients were better on the desiccated thyroid compared to the T4, T3. Some patients had abnormally low TSH and elevated free T4 and free T3 levels. It only persisted a short time because of dosage adjustments that varied among patients. And they did not find any difference in levels of patients according to the etiology of their hypothyroidism, whether they had Hashimoto's or surgically induced hypothyroidism or other causes. This article published by Pepper and Casanova Romero was in 2014. And they took patients that were on levothyroxine, switched them to Armour thyroid, once-a-day treatment, and they took 154 patients. And the patients preferred the Armour thyroid over the levothyroxine in 78% of the patients, with improvement in subjective symptoms. There were no side effects, and they felt that the patients did quite well on the desiccated thyroid, in this case Armour, compared to levothyroxine. This article was published in Medicina. This also got a fair amount of publicity, and it was done mostly by people at Mayo Clinic. It was a mixed method study by evaluating the content of online posts from 3 popular hypothyroidism forums from patients' desiccated thyroid extract, with 673 patients. Nearly half of the patients reported that a clinician initially drove their interest in trying desiccated thyroid. Patients described many reasons for switching from a previous therapeutic dose to desiccated thyroid, including lack of improvement in hypothyroid-related symptoms, 58%, and development of side effects, 22%. The majority of patients described desiccated thyroid extract as moderate to majorly effective, 81%, and more effective than previous therapy, 77%. So again, a lot of patients liked the desiccated thyroid. It was associated with improvement in symptoms, 56%, and a change in overall well-being, 34%. 1/5 of the patients had thyroid side effects related to the desiccated thyroid. This study published in Thyroid, also an excellent journal, and I think about 2 years ago, was an online survey for hypothyroid patients, was posted on the American Thyroid Association website and forwarded to multiple groups. They were asked to rank satisfaction with their treatment for hypothyroidism and their treating physician. They reported the therapy was either levothyroxine, LT4, LT3, or desiccated thyroid extract. And individuals taking the desiccated thyroid extract had a higher median treatment satisfaction compared to other treatments. At the same time, the levothyroxine group had the lowest satisfaction, and for the T4, T3 combination, the satisfaction was in the middle. Respondents taking desiccated thyroid were also less likely to report problems with weight management, fatigue, energy levels, mood, and memory compared to those taking T4 alone or T4 plus T3. So overall, there are 7 peer-reviewed publications that show desiccated thyroid extract was preferred over levothyroxine, and some articles over levothyroxine T3 combinations. There was no study showing that the T4 was better than the desiccated thyroid. So I think that idea that you're substituting an inferior product and you switch someone to desiccated thyroid, it really is not supported by the literature. The side effects, including hyperthyroidism, were minimal, and patients really do seem to feel better on desiccated thyroid. This was reviewed in a Medscape review that the citation is there. And this is a fairly new article, and I think this came out in 2023 and got some publicity also on Medscape, and I think people heard about this a lot. This article, I think was in just a couple months ago, looked at the prescription for desiccated thyroid extract to treat newly diagnosed hyperthyroidism. It doubled between 2010 to 2020, while prescribing the first-line levothyroxine monotherapy decreased. The first-time thyroid hormone replacement for desiccated thyroid went from 5.4 in 2010 to 10.2 in 2020. At the same time, prescriptions for levothyroxine dropped from 91.8 to 87%. Prescriptions for T3 in combination with levothyroxine, usually it's only 2%. So, 5 times more people are using desiccated thyroid than T3. Still, most of the people are given levothyroxine, but this has decreased a lot. They quoted some people in the Medscape article about this. One of the thyroidologists, Adthyza, said, what possibly may be the existence of online materials saying negative things about levothyroxine. So the people who are just learning about hypothyroidism might already be primed to think about alternative treatments. Interesting. Moreover, some patients may view desiccated thyroid as more natural than levothyroxine. Dr. Pierce says, I don't see DTE in Boston. It's mostly in the South and Southwest. She said she doubted that endocrinologists were the primary prescribers of DTE, as many endocrinologists are wary of the pig thyroid-derived product. She says, quote, there's a lot more work to be done, but I think it's exciting. It's important to see how patients are being treated in the real world and understand why it's happening and what the outcomes are. My comment is I think that people are really using desiccated thyroid because it works better. I think that's the bottom line. Okay, so what about having a suppressed TSH? Is that a problem? And I think not. The main problems are twofold with having a suppressed TSH. First of all, your heart, and second of all, your bones. And I think in a younger person, you're more concerned with the bones. An older person, maybe more the heart. I use a test called a urine N-tiolepeptide. It's commercially available at LabCorp and Quest and others. They measure the concentration of N-tiolepeptide in bone collagen equivalents over the creatinine in milligrams per deciliter. The range at LabCorp is 5 to 65. So if you're high, that means you're breaking down more bone. And then I'd be concerned about you're over-treating somebody and you have a suppressed TSH. I usually do this every 6 to 12 months, and I aim for less than 60. So that's one of the things I do to make sure that I'm not giving a patient harm by giving them the desiccated thyroid, which can suppress their TSH. The second concern would be atrial fibrillation. I think this is fairly uncommon, certainly very unlikely in a young person. But I would say using desiccated thyroid in an older person having a suppressed TSH, you may just want to be a little bit more cautious because of this concern about cardiac and atrial fibrillation issues. I usually have people take the thyroid medicine first thing in the morning on an empty stomach, 45 minutes from food, take the second dose mid-afternoon. Avoid taking with iron, calcium, vitamins with iron or calcium, proton pump inhibitors, probably should avoid carafate, bisphosphonates like such as Fosamax, orlistat, and cholestyramine. I don't see that much of effect of soy on the absorption. So let's talk about some of the different treatments. Start off with the desiccated thyroid extracts, go a little deeper into that. So Armour Thyroid is the product that everybody knows about. It's been in existence for 100 years, since the 20s. I think Armour is a company that makes hams. And my thought is, and I haven't found this that much in the literature, but I think they had their thyroids they had to take out from when they were making the hams because they didn't want to get people to get hyperthyroidism. So they decided to use that thyroid and went into a business to make the desiccated thyroid. And that was used since the 20s. Liothyronine started appearing in the 50s. President Kennedy took liothyronine. And then it's probably around 1960, levothyroxine or Synthroid was made by Dole Pharmaceuticals and was heavily marketed. So then about, sort of in the 60s, I would say 60s and 70s, desiccated thyroid started going out of favor. And then more recently, there's more of an interest in bringing it back. And as we talked about before, quality of life issues, people see it more natural. And most of the guidelines from American Thyroid Association does not recommend the use of desiccated thyroid. I think this is erroneous. So Armour is the first product. There is on clinicaltrials.gov a study comparing thyroid to synthetic thyroid. It was funded by Allergan, started in 2019. And if you go to clinicaltrials.gov, it still lists this is a pending study. The second product is called MP Thyroid. It's available now. It's called MP Thyroid, made by Acela. It's an excellent product, reliable. I use it a lot. It was recalled in 2020 due to issues with lot variants, but not since then. In 2021, CVS made a business decision not to stock MP Thyroid, saying it's on back order. I think that lasted for about a year, but now it's quite readily available in both commercial pharmacies, such as CVS. Now, there's a new product that I like a lot called Adthyza. Adthyza is made by a company called Azurity. It came out in 2023. It's lactose-free, gluten-free, corn-free, dye-free, and latex-free. And it comes into 16.25 milligrams, 32.5 milligrams, 65 milligrams, and 97.5 milligrams, and 130 milligrams. I think it's going to be a game changer. The company is sort of a major company. They focus on innovative products that meets the needs of patients with underserved conditions. Each lot of the T4 of the Adthyza, they measure the concentration by LC assays of the T4 and T3 to make sure the product meets the USP specification standards. So each lot is individually tested. You can look at the lot number on your bottle and look it up online and see exactly how much T4 and T3 are in it. And this is important because, there was questions before about the variations of the lots causing the recalls of MP thyroid in the past, and previously at the WP thyroid and the Nature Thyroid. So I think this is a really good product that it is individually tested. We know that each lot has the right amount of T4 and T3 in it. They also have a Adthyza Cares program. You can pay as little as $30 per month for a 90-day supply, or $35 for a 30-day supply. I'm not sure that price is valid because I think that's for once a day dosing. As I mentioned, it should be twice a day. So it might be twice that, but it's, in the scheme of things, it's not too expensive. I think some pharmacies are covering, some insurances are covering it, but if it doesn't cover it, you can do this Adthyza Cares program. Another product that is quite good and well used is Tyrosint. It's a T4 product only. It's a gel capsule, or you can get it in the liquid form. It has almost no binders or fillers. There's less interference with other medicines. It doesn't need acid in the stomach for absorption, so you can take it with antacids or PPI inhibitors. It's expensive and often not covered by insurance. They have a liquid dose that's available. What I often do is I have a patient that really wants to go slow. You can start with a liquid, put in a glass of water, and take half the glass of water, and then go to the full glass of water. And there's multiple doses that are listed here for both the liquid and the gel capsule. There is a generic Tyrosint. It's made by Lanet, which is the company that makes Unithroid. It contains levothyroxine, gelatin, glycerol, and water. no dyes, it's gluten and lactose free, it's manufactured in Switzerland, has similar type of dosing. And it's not that clear to me that it's less expensive than the brand, but it seems like, for at least for some people, it's a good option for you if you want to give the tyrosine. Then there's this product called Thyroid. I don't think this is caught on too well. It has a little, comes out with a little syringe that you can titrate the dose based on the amount in the syringe. It's an oral solution that's 100 micrograms per 5 mLs. It has inactive ingredients, citric acid, monohydrate, glycerin, methylparabin, sodium hydroxide, and purified water. It's made by Vertice Specialty Group. It allows gradual dose adjustments. You can use a calibrated oral syringe that can meet your patient's unique needs. It's gluten-free, sulfur-free, lactose-free. It's in 2 packets of 2 100 ml bottles, and they also have a copay and savings card available. Now, what about T3 alone treatment? T3 is cytomel, generic is liothyronine. Selly, who was at NIH, where I used to be, published in JCNM in 2011, that patients on T3 alone had better lipid profiles and had lower weight than those on T4 alone. So I thought this was an interesting paper. I use T4 in combination with T3 in combination with T4, sometimes even with desiccated thyroid. Many of the functional doctors, including potentially people in this audience, use T3 alone. I don't really recommend that for several reasons. First of all, the studies have shown that T4 gets in the brain much better than T3 does. Once it's in the brain, the T4 can get converted to T3. Therefore, in patients only on T3, the level of thyroid hormone in the brain might be quite low. Additionally, T4 has a long half-life and acts sort of as a reservoir, while T3 has a short half-life and should be given a couple of times a day if it's not in combination with T4. I also think it's unphysiological to have a very low T4 level, which is what happens if somebody's truly hypothyroid and taking only T3. If somebody who's misdiagnosed and really did not have hypothyroidism or has very mild hypothyroidism, the T4 could be even normal or detectable when only on the T3. But if you're truly hypothyroid, you go from T4 to T3, not T3 to T4, so you would have a low T4 level. I usually do not give T3 alone, as I like the long-acting reservoir of the T4 with a shorter acting boost effect of the T3. Then let's move on to reverse T3. The concept of reverse T3, it has to do with these deiodinases. Circulating T3 is derived from the type 1 deiodinase. This can occur at the outer ring of the T4, producing T3, or the inner ring. The outer ring would be over here. The inner ring is over here. And if you do the inner ring, you get reverse T3. This is by the type 3 deiodinase. There's also the type 2 deiodinase in the pituitary that converts T4 to T3 and is regulated differently from the type 1 deiodinase. Reverse T3 is a biologically inactive form of T3 that may block T3 from binding to the thyroid hormone receptor. Many years ago, endocrinologists realized that in severe illness, the type 3 deiodinase increases and you get high reverse T3 and low T3. Endocrinologists termed this the sick thyroid syndrome and noted that it was common in many types of chronic illnesses, especially in patients hospitalized in intensive care units. It was usually recommended that these patients not be treated with thyroid hormone. In most cases, the elevated reverse T3 resolved when the patient's health returned. However, more recently, some doctors, including functional medicine doctors, have made an issue about the reverse T3. They are going to think very appropriately that a high reverse T3 is bad, can block the T3 from binding to the thyroid hormone receptor. They pointed out that reverse T3 can go up in various conditions, including systemic illness, stress, inflammation, chronic pain, diabetes, weight gain, and depression. And they have quoted some articles that certain diseases are correlated with high reverse T3, but don't necessarily show that the reverse T3 leads to that disease. And these doctors and many other doctors have rely heavily on the reverse T3 to treat patients that have no other laboratory findings of hypothyroidism, and often give them T3 only preparations to try to lower the reverse T3. I haven't seen any publications on whether this is effective or not. And I think it's a little bit of a danger to put people on with completely normal thyroid function tests, except for a high reverse T3 on thyroid medicines. They also use a high reverse T3 to T3 ratio as a further indication to treat these patients. I got this slide from a website of a doctor that advocates T3 and measuring reverse T3. Factors that contribute to the production of thyroid hormones include nutrients, iron, and that's why I think it's really important to get somebody iron replete, iodine, tyrosine, zinc, selenium, and vitamins. Factors that inhibit proper production of thyroid hormone: stress, infection, trauma, radiation, medications, fluoride, toxins, celiac disease, pesticides, mercury. Factors that increase the conversion of T4 to reverse T3 include stress, trauma, low-calorie diet, inflammation, toxins, infections, liver, kidney dysfunction, and certain medications. Well, factors that increase T4 to T3 conversion include selenium and zinc. And it shows here that the T3 and the reverse T3 compete for the binding site. And if you have too high a reverse T3, your T3 doesn't bind to the binding site. I think that's true. Factors that improve cellular sensitivity to thyroid hormones include vitamin A, exercise, and zinc. So what we did is I had one of my students help me out on this, where we submitted this in abstract form. We're trying to get the paper published here. We took 976 consecutive patients who came to see me with potential thyroid problems. Many of them were on thyroid medicine, some were not. They all had symptoms and signs of hypothyroidism. Most of them had a lot of fatigue. Many of them were already treated with different thyroid preparations. I used the upper limit of normal for reverse T3 at Quest or LabCorp, which is usually 24, and I did not calculate any type of ratio. So this is our data so far. The cutoff of the reverse T3 of 24 is given in the red line. This is a box of whisker plot, and you can see the none group is in this blue here. 31 out of 345 patients had a high value, so about 10%. The next group is on desiccated thyroid alone. The next group, and there was 8 of them that had an elevated value out of 226. On the desiccated thyroid plus T3, none of them had an elevated value. On the desiccated thyroid plus T4, 24 out of 138 had an elevated value. On the desiccated thyroid plus T3, T4 combinations, 2 out of 7 did. I didn't have too many patients in that category. And patients on the T4, T3 combination, we had 23 of 23 that had a value high. And most importantly, though, T4 alone is in this dark blue color, 29 of 139. So that was the highest ratio of patients that had the higher values. You can see many of these values up in here are quite high. And on the T3, so the green, was the T3 alone. And then the maroon here is the T4, T3. Also a fair number had a high value here. We did get IRB approval for retrospective analysis of this. Of the patients that were on the levothyroxine group, their RT3 was 18 compared to the group that not on the levothyroxine, on either desiccated thyroid or T3 or combinations, was 15. This was highly significant. And the percentage of patients with a reverse T3 greater than 24 was 17.7%, while only 6% on the not on the levothyroxine group. This was also highly significant. So the number of patients with RT3 above the range varied significantly with a type of thyroid hormone treatment. The highest rate of elevated reverse T3 was in patients taking T4 alone, 21%. 9% of patients not taking thyroid hormone had an elevated reverse T3 value. In contrast, only 4% of the patients taking desiccated thyroid had a high value. 12% of the patients taking T3, T4 combinations, and 17% of those taking desiccated thyroid T4 combinations. Patients on all types of levothyroxine treatment had a higher reverse T3 than those not on levothyroxine treatment, and a higher percentage of reverse T3 above the cutoff of 24. So overall, the levothyroxine had the highest amount of high reverse T3. We did a linear regressions. The RT3 was strongly correlated with the free T4 levels, but not with free T3 or TSH levels. I didn't look at whether the high reverse T3 was correlated with hypothyroid symptoms. And I have patients certainly with a high reverse T3 are doing fine, and those with a low reverse T3 that are not. But I certainly think this is an important avenue to explore. So measuring reverse T3 may be helpful in some patients, especially those on thyroid hormone treatments that contain T4. Patients that have an elevated reverse T3 on thyroid treatment with either T4 alone or T4 plus desiccated may benefit from decreasing the amount of T4 given and increasing the amount of T3 given, or the desiccated thyroid given. This area of reverse T3 is clearly an interesting area. So far, there's a clear division between endocrinologists who don't measure at all except for me, and functional doctors who measure almost everybody and treat most people for it. I think this test could be helpful in certain patients. I think some discretion needs to be given on who gets thyroid medicine, especially for the rest of their life, and who does not. I'll talk about biotin for a couple slides here. Biotin is a supplement, usually often used for hair and nails. The American Thyroid Association states that biotin use can result in falsely high levels of T4 and T3 and falsely low levels of TSH, leading to either wrong diagnosis of hyperthyroidism or that the thyroid hormone dose is too high. The ATA has recommended the patient stop taking biotin for 2 days, at least 2 days before thyroid testing, to avoid the risk of having a misleading test. There's no series on this. There's just case reports. It seems to be only if someone's taking 20 milligrams a day of biotin, which is 20,000 micrograms. Most supplements contain at the most 10,000 micrograms, 10 milligrams or less. So I think most people will be okay. If somebody's really concerned, if they really have funky thyroid tests, they could stop their biotin for 2 days before. But I think this is an overblown concern. From Quest, they have a table that says what tests biotin interferes with. And interesting enough, free T4, free T3, and TSH are not on this list. So at least according to Quest, it's really not a concern. It could be a concern for some of the other tests, but we don't tell people to stop testing if they're getting their thyroid globulin measured or their gastrin measured or B12 measured, although potentially they should. But I think it's really a condition of much higher doses than what is commonly used. Okay, what about a thyroid diet? This has been some talk about what kind of thyroid diet people should be on. I recommend a clean diet, just like I recommend for all my patients. Lots of fruits and vegetables, limit processed food, limit simple carbohydrates. Otherwise, there's little data on any specific type of diet for thyroid disease patients. Many functional doctors have promoted diets to address leaky gut, which is a condition not recommended by most endocrinologists or most physicians. There was some nice review articles on Hashimoto's, and the Hashimoto's is not really considered a disease of inflammation. I'll show that on the next slide. So the fact that you need to have an anti-inflammatory diet, I'm not sure that's grounded in literature. I don't believe you need to have a gluten-free diet. There was this Medscape article by Angela Leong, and she sort of basically agreed with me that there's no really such thing as a thyroid diet. It should be a healthy diet. This is a review article about thyroiditis, and it has different environmental factors that can lead to thyroiditis, including smoking is a protective effect. Infections can lead to it. Irradiation is a little bit of effect, possibly. Vitamin D deficiency, weak evidence. Selenium deficiency, modest evidence. No discussion of gluten, no discussion of inflammation. In terms of selenium, I think selenium can be helpful. Selenium has been shown to increase T4 to T3 conversion and reduce the TPO antibodies. Patients with untreated growth hormone deficiency have decreased T4 to T3 conversion. So there would be one group of people that you might put on selenium, but you should also put them on growth hormone. However, there's some literature about selenium appear to increase the rate of diabetes. So I'm a little bit cautious about giving selenium to those patients with prediabetes or diabetes themselves, or with a pretty strong history of family history of diabetes. So overall, your diet should be a healthy diet, exercise, have your thyroid properly treated, and you don't have to be gluten-free. So I especially want to thank Sahar for organizing this, and Gina, I hope I pronounced your name right, and for inviting me. And I guess we have time for some questions. Sahar, how do we do the questions?
Yes, thank you. That was awesome. That was great. Yeah, so do you want me to read them so you can go to the QA box, or do you want me to just kind of go through them? What would you like?
I can go to the QA box, I think.
Yeah.
Share my screen, and why don't you read them? Sure. Give my voice a rest.
Yeah, so I tried to kind of collate them because sometimes there's a common theme, as you know.
Sure, go ahead.
Okay. So since we kind of finished diet, autoimmune, thyroiditis, things like that. So there was a lot of questions, on Hashimoto's, and also like some heard that you should not use desiccated, thyroid products in autoimmune type disorder, just because they're similar to your own gland and the body can kind of attack, if you will. So what are your thoughts on using desiccated thyroid?
Right. So no evidence for that at all. And I think in general, if some studies have shown, if anything, Hashimoto's patients do better on desiccated thyroid extract. You're not giving it like IV that you can have an immune response going. You know, goes into your stomach and gets curated. So I think there's no evidence of that. I think patients with Hashimoto's do fine on desiccated thyroid.
And then kind of to piggyback on that, they were asking, you know, what are your thoughts on, do you see, is Armour more prone to causing autoimmune flares than MP? Then, you know, sometimes because they see erratic TSH type levels, even sometimes when the dose is consistent, if you will. So what are your thoughts on just erratic TSH levels in general? And do you see a difference between the various desiccated thyroid products?
So I don't see much of a difference between the desiccated thyroid products. I don't think any of them are more likely to cause autoimmune problems than other, or more likely to be variable. I think the lots of all of them are pretty good, and I think they're pretty standard. As I mentioned, I try to move a little bit away from a TSH-centered approach, so there could be a little bit of variation in TSH. TSH does vary both the time of the day it's checked in, the time of the year. The TSH is higher in the winter than the summer. So some people may have, just a variation from TSH, regardless of whether the dose is the same. I try to look at the symptoms and the overall TSH, free Q4, free Q3, reverse T3, and decide whether I need to make an adjustment.
So as far as kind of natural supplementations, what are your thoughts on iodine? And sometimes some providers recommend higher dose iodine. Do you see it possibly causing autoimmune thyroiditis if it's excessive? And selenium, the diabetes, pre-diabetes, we talking like just the general 1 to 200 mics range, or do you see that in higher, dosing?
Right. So the selenium dose, I like the 200 microgram dose. You can't get it at Trader Joe's, so it's pretty inexpensive and easily available. The iodine, I'm not a big fan of. I think the studies I think most people in the United States are on adequate iodine. And I think the studies showing that iodine is helpful are not that much. There are conditions that iodine can both exacerbate hypothyroidism and hyperthyroidism if it's sort of borderline and being untreated. Patients that, like, for example, come from an iodine deficient area like Ethiopia, let's say, they come to the United States and they get exposed to a lot of iodine. It could make them become more hyperthyroid. And there's also some idea about iodine can suppress your thyroid and give you hypothyroidism. So I do think the people that are on that need thyroid medicine should go on thyroid medicine, that they shouldn't go on iodine. Selenium is a possibility for somebody that has sort of a borderline TSH. Also minoxidil has been found to help lower TPO antibodies and TSH in people that are sort of borderline. So I think there's a question here. If somebody has a TSH of, let's say TSH of 3 and their antibodies are negative, or 4 and their antibodies are negative. I think somebody like that can go on selenium potentially, or the minoxidil and not get treated. But I think the people that really do need treatment should go on treatment.
Low dose naltrexone and, Hashimoto's, what do you use that? What are your thoughts on that?
Right. I don't use that either. I don't think there's much literature on that. I think the idea would be that it would, is sort of autoimmune and maybe suppress your attack of your gland. But I don't particularly use it. In general, and I know the people, I have plenty of patients that are on and like it, but sort of the idea that you're blocking your own natural endorphins. I think you need your natural endorphins. I think they're helpful for pain, and seems a little unusual to try to block something that's so good as endorphins.
So what are your thoughts on, well, first of all, do you always check antibodies and how often? And then B, what are your thoughts on lowering them? Like, how do you help your patients lower their TPO level, especially in resistant type patients? So let's say, we give supplementation, cleaned up diet, all that, stuff, if you will. What are your thoughts on lowering TPOs and how often are you monitoring?
So in my initial patient, I always measure TPO. And I do that, first of all, I think the patient wants to know, and I sort of want to know. It's helpful for screening family members. If you have a TPO antibody, the family members, especially females, should be screened for hypothyroidism. And you also have, a predilection to other autoimmune diseases, like such as celiac disease and B12 deficiency and Addison's disease. So the new patient, I would always measure it. In patients that are already on thyroid medicine, I'm not that convinced that having the TPO antibody of 20 is that much better than a TPO antibody of 1,000. They're still going to need their thyroid medicine. If you're maybe trying to take somebody off of thyroid medicine, some people were, I always joke that I spend half my time putting people on thyroid medicine that are supposed to be on it, and half my time taking people off thyroid medicine that shouldn't be on it. So if you're trying to take somebody off, it's probably helpful to measure TPO, and maybe if it's borderline, trying to lower that. But I think once the cat's already out of the bag, they're already hypothyroid, they're already on medicines, I don't think it's that important to either measure it frequently or try to lower it, unless there's some kind of reason that you want to try to get the patient off of it.
Okay, I guess let's finish this immune story because it keeps. So EBV, autoimmune thyroiditis, do we think like EBV obviously kind of resides in a lot of tissues? Do we think it's more, attacking the immune system, just more preferential to the thyroid?
I don't think there's a relation to EBV and thyroid disease.
Okay, so let's talk a little bit about testing. So there was a few questions as far as, let's see if I can summarize a lot of these questions. So when are you testing TSH, morning, evening, high, nadir dose, peak doses? And also just in general, when you see, let's say suppressed TSH with a pretty normal T3, T4 levels, free T3 in total and all that stuff, and how comfortable are you? How long do you let the TSH ride? How high, if you will? Besides, thank God the Endocrine Society lowered that. I think it used to be like up to 10, don't freak yet, but now that's better, at least a little bit.
Okay. So first of all, I think some of my endocrine colleagues still use a TSH at 10 to start treatment. I think that's wrong. So I think there's sort of two issues. One is who should start treatment, and what's the optimal treatment. So I usually don't start treatment. And I think somebody asked about a TSH of 1.2. I usually don't start treatment until somebody has a TSH, this may be 3.5 and antibodies, or a TSH of 6 without antibodies. So I use those antibodies a lot, who should start treatment. And then once you're on treatment, I don't mind having a low TSH with a caveat that I want to assess their bones. I get that urine inhaled peptide at every 6 months or so. And, I want to at least think about, are they at risk for getting atrial fibrillation from too much thyroid medicine? So I'm okay with somebody having a TSH that's low with a normal free T4 and free T3, as long as they're not having hyperthyroid symptoms and not as long as they're not breaking.
How low? Like
I think it could be 0.
Okay, and does age matter?
Yeah.
So TSH of 0. Would you feel comfortable in that in a 20-year-old or a 75-year-old?
Right. So yes, a 20, probably no in a 75-year-old. Exactly.
And what's your threshold for, let's say, the older geriatric population with a TSH level of how low do you feel comfortable, let's say?
I think it depends on how, what the risk factor is, but maybe a TSH of 0.1 I might go down to if somebody has a little more risk factors. Again, I'd like to get that urine inhaled peptide, look at the bones. Maybe 0.1 would be my cutoff for a patient above 70.
And so as far as testing, do you like morning TSH plus the full panel that we discussed? And if they're on BID dosing, when do you usually like to test?
Yeah, so I like to test in the morning, but I have them withhold their T4 and their T3 or their desiccated thyroid till after the test. We actually did a study when I was at the NIH that if you take your thyroid medicine before your dose, your TSH drops like 10%. So even though the T4 is sort of a long half-life, the TSH is sort of a long half-life, in general, I'd rather people be like at a trough level without their morning dose and get their blood test in the morning.
So you test it in the morning, hold the AM dose to kind of get a trough, if you will, versus
right.
And BID dosing, same thing if it's BID.
Thing, right. It's better. It's more clear if it's BID, sort of a little smoother. If if you do once a day, you test it the next morning, then you're almost always going to have a low free T4 and free T3. So that's why it's really supports doing the twice a day dosing. And then you have people that do get their tests, their free T4 and free T3 after their morning dose, and it's high, and then you have to decide what to do about it. So if it's a little bit high, I just have them repeated next time before their morning dose. If it's a lot high, then you probably need to cut it down still.
And then, so if somebody either turns, maybe they're overdosed, so hyper, or maybe they don't need the med as much, do you recommend tapering? And if so, how are you weaning? What's your general methodology?
So I go slow. It depends on how high they are. If somebody has a free T4 of 11, I'd probably drop them down more. And then the free T4 is 5.4 and the normal's up to 4.8 or so. So, let's say I have somebody on MP thyroid, 60 milligrams twice a day, and their free T4 is free T3 and free T4 are high. I might go to 60 milligrams in the morning and 45 milligrams in the afternoon, which would be a 30 plus a 15. So, I would like to make fairly mild, slower changes. But, if there's quite high, then you would cut them down more.
Do you usually, if they're really high, do you block with protect the AV node, let's say, with propranolol or anything like that? No,
I would just have them cut down right away. Some people I would stop it right away, and give up like a holiday for like 2 or 3 days, and then cut it down. There's a study I just read that propranolol blocks your melatonin. I think people need melatonin to sleep, so I really don't like beta blockers too much.
Okay, and then, so do you have, optimal, well, first of all, I have a general question. How can we get your colleagues and just everybody in the world to just check more than TSH? Do you have any thoughts on that? Because it's, this comes up a lot. It's very frustrating.
I think this endocrine news perspective was very important. The endocrine news is read widely by endocrinologists, and the person from Australia, is pushing, made a good case for that. Certainly people are doing, more T4, T3 and desiccated thyroid. And, like the articles I presented showed more people are on desiccated thyroid. I think the tide is shifting. And I think as an endocrinologist, you have to sort of distinguish yourself from a primary care doctor. So if you're just giving people T4 and just measuring TSH, I don't see why they need to see you, basically. So I think endocrinologists, if they want to survive, do well. There's actually not enough endocrinologists around, but I think if they want to sort of capture the market, they need to think creatively, and I think that'll be the best interest of their patient.
Is there any, optimal levels that you normally shoot for, or is it just kind of, how the patient feels in addition to that? Because, so for example, we see a lot of patients are asking, let's say I'm desiccated thyroid, low free T4, but good free T3 and low TSH, or at least in range. Or sometimes, the TSH is not, TSH is really suppressed, which we covered a bit, how low do you go and when, with the proper monitoring. But sometimes like the HPA axis loop, as I call it, it's not connecting well. What are your optimal levels that you look for to kind of complete the entire picture?
Yeah, so I try to complete the entire picture. I look at symptoms, signs and symptoms. And, I like the free T4 and free T3 to either sort of be in mid-range or maybe a little bit on the upper part of the range, as long as I'm not having hyper symptoms. I don't want the reverse T3 to be too high either. As I sort of use the cutoff, the top of the range. If it's too high, I would probably maybe add some T3 and back down on the desiccated thyroid, back down on the T4. The patients that you described with sort of the low free T4 and higher free T3 might be on once a day dosing, and they should benefit from twice a day dosing. And so you have to look. I try to look at all the labs. So if somebody truly has a low free T4, the reverse T3 is not high, I could add some T4 back to it.
So, and I think you answered this already, but so, if someone's TSH, free T3 and free T4 is within range, but the antibodies are high, should you treat if they have hypothyroid symptom, even though the levels are good? But
So I think
TPO high,
right.
symptoms.
That's a tough question. So I think somewhat depends on TSH. If it's above 3 or 3.5, I would treat. If they have a lot of symptoms, you sort of exhausted everything else, I think a trial might be okay. There are also a percentage of people that have a negative TPO antibody, but a positive thyroid ultrasound that shows like a heterogeneous, increased echogenicity of the thyroid. So I might do a thyroid ultrasound of somebody that's sort of borderline.
And then how often?
And then that kind of person also might be a good person to put on selenium.
Mm-hmm. How often are you monitoring your patient after either the start of therapy or continuation of therapy? How often are you checking the panel?
If I had unlimited time to see my patients, I would probably do it every 6 weeks, 2 months. But I sort of book out pretty far, so I usually do it every 3 months. And then, sometimes when I start a patient or a patient's not doing well, I would probably do it sooner. I have patients that are stable. You can push it out to 6 months or so, or a year even.
And do you have like an optimal ratio of free T4 to free T3? Do you use that in your treatment, like the ratios?
Not really. I try to have both of them sort of mid to upper range. And then I use the reverse T3 a little bit to guide me if they need more or less T3 added. Maybe we'll take one more question.
Well, we have a lot, so you tell me when do you want to stop?
Yeah, just one or two more questions.
Just to be exactly respectful of everyone's time.
Right.
Before so I think, let's see, this is probably a good question. I think a lot of the other ones we touch base. Thyroid ultrasounds, obviously nodules are very common. How do you use ultrasounds to guide therapy and assessment? Do you ever use them, or just when the patients are in this kind of like the patient we just discussed, where maybe let me get an ultrasound and kind of look at that?
So, ultrasounds are important for nodules. Somebody that feels a nodule, they should get an ultrasound for sure. The problem we have nowadays is people get find it, and this is a completely different talk. We can do this some other time, but people find an incidental nodule. They get a head CT scan. It shows a thyroid nodule on that. They don't feel it. Those are almost always benign. They're overworked up. They're overtreated. Very few people die from thyroid cancer. So I think those people, we should sort of back off a little bit. I use the thyroid ultrasound. Somebody has symptoms of, pain in their thyroid and they feel a nodule. I think sometimes I use it for the people that I can't decide if they have Hashimoto's or not. Their TPO antibodies sort of like right around the cutoff. I think they have it, but the TPO antibody is negative. So that's when I would do it.
And probably the big topic we didn't talk much about, thyroid in pregnancy, the use of desiccated thyroid in pregnancy.
Yeah, I'm in favor of it. I think just as you need to have, sort of good T4 and T3 levels in non-pregnancy, I think you need to have good free T4 and free T3 levels in pregnancy. The pregnancy issue is more concerned. You're more concerned about hypothyroid. And, if somebody isn't converting T4 to the mother's not converting T4 to T3 well, potentially their baby could also not convert it. And I think it's properly important to have sort of, good replacement, including T4, T3, adequate levels in pregnancy.
Last question. They're asking for the slides. Do we have your permission to share them with them?
Yes. So this is my website. And I'll put them on my website. What do you have a website you put yours on?
Yeah. So actually, the Yes, we'll just do some kind of whatever quaffing, as I call it. IT will quaff the presentation. They will post it on our A4M website. So all of the live recording will be there, and anybody can go there to the A4M website and see this. Now, as far as these slides, we will PDF them and mail them to the audience that registered. And like I mentioned, we have close to 900 that are registered for this. So it will be sent to those. But also, if you'd like to post them on your website, we can absolutely kind of guide them to that also, in addition to emailing them to the audience. Well, thank you.
Thank you so much.
So much for attending this evening. It was a pleasure. Dr. Friedman, always a pleasure, always a wealth of information. Thank you for your time and expertise as always. And thank you for helping us to continue to educate all of us on just better endocrine management of all types. So hope to have you again very soon. Thank you again.
Good night, everybody.
Good night, everybody.